Medicine is a social science, and politics is nothing but medicine on a large scale. And if you hold someone accountable for something they cannot control, you are not creating accountability. What you're creating is called burnout. This is the sixth and final video in my series called Healers to Health Keepers. In my previous videos, I looked at how American healthcare transformed from a system where we're building public health infrastructure into a system where we now blame people if they fall sick. That is, if you get diabetes or heart attack, the current system blames you because somehow it's your fault because you didn't take care of yourself. This is the political conversation going on today. So, how did we get here? How did we get to blaming people for their own sickness? All the historical events that I discussed in my previous videos, such as the publication of the Flexner Report, passing of the Hill-Burton Act, rise of risk factor medicine, quality measures, all of these, we've created what's called a new cultural hegemony. That is, the dominant thought of the times. And this thought process is that doctors can decrease your chance of falling sick. Now, while there's some truth to the statement, but on average, we can only help approximately 10 to 20% of the time. That's it. But because the dominant thought is that doctors need to keep people healthy, insurance companies, they started demanding it. And to meet this requirement, the system built a surveillance machine to document what we are doing to keep you healthy, to satisfy a third-party payment system. Initially, this documentation was limited to telling people to eat healthy and exercise in every visit, till they got sick of us. And this didn't work. And of course, we knew this wouldn't work. But we know that the strongest predictors of health are social. That is where and what we eat, where we live, where we work and play. So it was only a matter of time before these healthcare financiers, both the government and the private sector, started telling doctors to screen people for the social determinants of health, even if we couldn't do anything about it. Welcome to PCP Lens, where we journey through metrics, money, and madness. My name is Sudeep Bansal. I'm a primary care physician in Connecticut, and I run my own medical practice. In this video, I will look at how technocratic legitimacy, that is when people use technical jargon to mask political choices, is transforming social problems such as housing, food insecurity, and economic stability into clinical responsibilities. The 2001 Institute of Medicine report published an article called Crossing the Quality Chasm, and I've talked about this influential article in several of my videos before. And one of the big ideas in this article was that patient care should be patient-centered. And you think about the term patient-centered and you're like, duh, like patient care should be patient-centered, like what are you talking about? But the problem was that this term was so loose that over time patient-centered came to mean a lot more things. So patient-centered care started off with meaning that we need to respect patient preferences in treatment decisions. And that makes sense. But within a decade, it expanded to include cultural competence, then health literacy, and finally by 2010, it meant taking into account all the person's social problems in clinical decisions. Now again, we know that social problems affect health outcomes, but here's what happened. We linked patient-centered care to the social determinants of health, and that meant it somehow became your doctor's responsibility. In 2008, the WHO Commission comes out and says, people are getting sicker and someone needs to do something about these social determinants of health. But then the question became, who's going to do something about it? Enter the government with the Affordable Care Act in 2010. The Affordable Care Act in 2010 created what's called the Accountable Care Organizations, or ACOs, as part of what's called value-based care. Now, under these ACOs, doctors, hospitals, and any other clinician that takes care of patients could band together and take accountability for what's called the total cost of care. Now, we already know that hospitals are not interested in decreasing the total cost of care because how are they going to build all of those expensive buildings? So this whole thing fell onto primary care physicians. So how does this work out in real life? If one of my patients from Connecticut travels all the way to California and unfortunately gets into an accident there, it is somehow my fault. I should have done something to prevent that hospitalization. And all of the costs of his hospitalization treatment in California gets attributed all the way back to me. Now, some people might hear this and say, like, this is unfair characterization of the Affordable Care Act. But then my answer to that is, the Affordable Care Act creates many, many more problems than it solves. This is just one example of that problem. So under these contracts, if an ACO's patients cost more than the projected budget, it gets taken out from the money paid to doctors. And for some ACOs, this can sometimes be in the millions of dollars. On the other hand, keeping costs below projections means shared savings, that is, a bonus. Now, since social issues are often the reasons for expensive emergency room visits and hospitalizations, suddenly the fact that someone doesn't have a place to stay and ends up in the emergency room is the ACO's responsibility. Because if this person keeps going back to the emergency room and keeps getting hospitalized, the insurance companies will take the money back that they have already paid for the care that we've provided. Not to be outdone, the Institute of Medicine, which rebranded itself as the National Academy of Medicine in 2014, comes out and says, well, since social factors affect patient outcomes, all doctors need to collect data on patients' social problems. Oh, and by the way, this data is an essential part of clinical care. Now, the fundamental mistake that the National Academy of Medicine made was asking doctors to collect all the social and behavioral data during individual clinical encounters. So now, instead of taking care of your hypertension, diabetes, and cholesterol, we now have to spend time collecting all of this data on patients. And we're not done yet. Since doctors refuse to collect all of this data, CMS starts creating standardized screening tools on the social determinants of health to make life easy for doctors. Now, these screening tools are called the Health-Related Social Needs, or HRSN. Now that CMS had the tools, then they made them into quality measures, first for hospitals in 2024, and then for primary care coming in 2026. Now CMS has a stick. If doctors don't collect this information, CMS will give us a pay cut. So in the last 10 years or so, this is what really happened. We shifted the blame for the social determinants of health from patients, because this is a touchy subject, to frontline clinicians by turning societal issues into individual problems. And here's how that plays out. Instead of people questioning politicians about why their policies failed or why they are not implementing policies to improve the healthcare of the people, the question now is redirected to doctors on why we are not doing anything to help people who are sick. And mind you, this is not medical treatment. This help is trying to solve the socio-economic problems. Not convinced? Let's take an example. So now, instead of questioning why people are homeless, we now screen for homelessness when people end up in the emergency room, for example, with a heart attack, because we know that being homeless is a risk factor for heart disease. The question of why people are homeless is a policy question, but a quality measure for screening for homelessness requires clinical documentation and referral. So you see what we're doing? We're shoving social problems into clinical medicine. And here are some examples of Z codes that we have to document today. Z59 for homelessness, Z59.1 for inadequate housing, Z59.4 for food insecurity, 59.7 for insufficient societal insurance, Z60.2 for living alone, and Z65, which indicates that the patient has a criminal record. Now, we can document these codes all day long, but just documentation does not create housing or food. And you may have heard or read reports in the newspapers that some hospital somewhere discharged a patient on the street. How could they do that? That's so inhumane. But what you didn't ask was, why was there no place for this person to go when they did not need any acute medical treatment? And then also, we continue to wonder why healthcare costs are skyrocketing. So let's take another absurd example. If the patient doesn't have a refrigerator to store insulin, should the PCP or the ACO buy the patient a refrigerator to decrease their chance of hospitalization? Or for that matter, should Medicaid, which was enacted to pay for healthcare, be paying for housing? Why is there no separate budget for these social problems? But this is exactly what we are building. We are just hiding all of this absurdity under acronyms such as ACOs, VBC, SDOH, and HRSN. So you may have already guessed, we've continued to build the infrastructure to document, and document without any solutions. And since we made ACOs and doctors responsible for the total cost of care, value-based care has become a concealed effort to build a social safety net inside the only system that we are still willing to fund, which is medicine. We've defunded the public health system, the social services, for decades, and policymakers are now using value-based care to force healthcare to absorb all of these social responsibilities. Let's take another example of how this plays out in real life for a primary care physician. Mrs. Jones has diabetes and her hemoglobin A1C is uncontrolled at 9.2%. She comes into the office and we perform a screening for the health-related social needs, and she screens positive for inadequate housing. She doesn't have a regular place to stay, and because she doesn't have a regular place to stay, she doesn't have a place to store her insulin, and this is the reason why her diabetes is uncontrolled. But in my 15-minute encounter, even if I was able to find a housing program and fill out all of her referral paperwork, there's still generally 1 to 2 year wait for most people to get a place to stay. However, next quarter, I'm going to get a report from my ACO or from the insurance company that Mrs. Jones has uncontrolled diabetes, and what am I doing about it? And if I have enough patients like Mrs. Jones, I am going to get financially penalized under value-based care. This is how this affects primary care at the front line. And this is one of the many reasons why PCP practices sold out to large organizations so that they could take a salary and let the suits handle all of these problems, adding to the administrative burden in healthcare. So essentially, we're demanding that doctors solve all of these social problems that require billions in investments with good intentions and referring people to often non-existent social service centers. And as much as we complain about the cost of healthcare and even access to healthcare today, the fact remains what we've created is medical abundance coupled with social scarcity. Our system will pay for a third-line chemotherapy treatment, which may or may not improve life expectancy for a few months, but we refuse to invest in the social determinants of health. Now, I've taken the example of homelessness before in this video to show you why it causes problems, and that's just one example. But let's put that in financial perspective. We spend approximately $40,000 to $60,000 annually on average on one homeless person for their health issues, which is often due to them getting their medical care in the most expensive place, that is the emergency room and hospitals. Now, for the same person, if we gave them a place to stay, it will cost us approximately $15,000 to $20,000, which dramatically decreases the chance of getting hospitalized. And that's how you save money. So for approximately every $1 that you spend on housing, we save approximately $1.8 in healthcare. And this is the American paradox. We spend approximately 17% of GDP on healthcare, almost double compared to our peer nations, and we have worse health outcomes. In contrast, we spend a lot less on social services, only about 56 cents per healthcare dollar. Now compare this to other peer countries that spend approximately $1.70 on social services. And now I'm well aware that every country has its problems, and every country is also struggling with healthcare spending at this time. But at the same time, the American paradox of spending is also true. Now, talking about other countries, let's take an example of the United Kingdom. They employ over 3,500 social prescribing link workers who connect patients to housing, food, and social services, which is outside of the clinical visit. So when a British patient struggles with housing, they see a navigator, not their general practitioner, which is their version of the PCP. A recent study found that this program decreased PCP visits by approximately 40% because they didn't have to take all the extra time to document and take care of all of these social issues. It also saved approximately 3.5 pounds for every 1 pound invested in this program. So now, PCPs have more availability to take care of patients' medical problems, and they also save more money. Now, let's take a look at the bar graph on this slide. This bar chart is from the Brookings Institution, and it shows that the United States spends significantly more healthcare dollars compared to what we spend on social care. But when you combine the two, we are right in the middle of the pack. So what we've really created is a great social to clinical funnel. And because we don't want to pay for social issues, the cost of taking care of social issues in America is written in every single clinical encounter. The root cause of chronic disease is not clinical failure. It is a policy failure to address clinical symptoms. The irony is that we recognized this issue and fixed similar problems in the 19th century. We built the sewers and the sanitation infrastructure that was required to eradicate infectious disease. But in the 21st century, Instead of focusing on commercial, political, structural, and the social determinants of health, we are blaming doctors for failing to eradicate chronic disease. If we really want to make a difference in decreasing chronic diseases, we need to invest in stable housing, living wages, reliable public transportation system, and a public health infrastructure. These are all legislative choices, not clinical workflows. And if we fail to do that, the cycle of chronic disease will keep continuing. Let's take an example of how this will work out in clinical practice with a fictitious patient. Imagine another homeless person, Mr. Jones again, with really bad COPD. He has had 3 emergency room visits, 2 hospital admissions in the last 6 months with an approximate total cost of about $120,000. So for each visit, the doctors in the hospital document that Mr. Jones is homeless. That is, they use the Z code of Z59. A social worker follows up and refers the patient to the shelter. However, given the lack of shelters, each time the person is discharged to the street, and people are outraged when a local newspaper covers the story. Eventually, the person qualifies for permanent housing, which costs approximately $18,000 a year. And then Mr. Jones, his emergency room visits drop to 0 and his COPD stabilizes. The sad part of the story is that we know that this works, but we waited till Mr. Jones felt sick enough to give him what he needed the most. Not medical care, a place to stay. And guess what? The cost of this housing is now part and parcel of healthcare dollars. So we are back to paying for sickness instead of keeping people healthy. Thank you for watching this video. Written version with the podcast is available on pcplens.com. Take care and goodbye.